Can everybody hear me and see my screen okay?
Yeah.
Good morning. My name is Matthew Darby, and my presentation is titled Understanding the Use of Occupation-Based Services in Acute Care Settings. My advisor is Dr. Shannon L. Scott, with committee members Dr. Julie Dorsey and Alyson Pasquale. In 2016, 35.7 million hospital admissions were reported in the United States, with the average length of stay being 4.6 days. It was determined that 31% of healthcare spending in 2019 went towards hospitals, signaling the importance of this practice area. Once patients are discharged from hospitals, they are discharged to home, inpatient rehabilitation, or skilled nursing facilities. Due to increased costs associated with readmission rates, there is an emphasis on reducing readmission rates, and legislation such as the Affordable Care Act and the Hospital Readmission Reduction Program were created to decrease healthcare spending. According to the National Board for Certification in Occupational Therapy's 2018 practice survey, 13.2% of registered therapists work in acute care, which is the 5th largest practice area. In the acute care setting, OTs use their unique lens to promote functional outcomes, safety, and performance of activities of daily living, or ADLs, which are activities related to self-care, while also considering the environment, such as the patient's home. OT also has a role in discharge planning and education, such as fall prevention. A 2017 study found that OT was the only discipline where increased spending lowered 30-day readmission rates. However, 72 to 79% of patients did not receive OT services. This shows that patients who may benefit from OT services may not be receiving them. The distinct value of OT is the use of occupation as a means and an ends. Occupation-based services, as defined in the Occupational Therapy Practice Framework, 4th edition, or OTPF, encompasses OT services that incorporate the use of occupation both during the evaluation and intervention process. The OTPF-4 is a guiding framework that defines the domain and process of OT. Occupation-based services in acute care have been found to be more effective, motivating, and individualized to patients. However, there are currently barriers to providing occupation-based services in acute care, such as large caseloads, lack of time, and exclusion from interdisciplinary teams, along with the potentially restrictive medical model structure of this setting. In summary, most patients who would benefit from OT are not receiving services. More of a biomechanical approach is being taken to providing OT, and practitioners feel disconnected with occupation-based theory. It is known that being occupation-based is OT's distinct value, and there is limited knowledge on how the profession's paradigm shift back to occupation has influenced OT practice in the acute care setting. Therefore, it is important to explore if that is being carried out in acute care. The purpose of the study is to gain a better understanding of current occupational therapy practice in acute care settings in the United States. I based my study off of the following research questions. 1, how and to what extent are occupational therapy practitioners providing occupation-based services in acute care? 2, what facilitates/supports occupational therapy practitioners' ability to provide occupation-based services in acute care settings? 3, what, if any, barriers impact occupational therapy practitioners' ability to provide occupation-based services in acute care settings, and what strategies are being used to overcome perceived barriers? This study was an anonymous survey created on Qualtrics based on a literature review in the OTPF-4. Additionally, prior to distributing the survey, piloting by an experienced acute care practitioner was completed and further refinements were made. The inclusion criteria for the study were OT practitioners who are occupational therapists and occupational therapy assistants in the United States, currently working in acute care, and who have done so for at least 1 year. After IRB approval, snowball sampling was used to distribute invitations to professional and personal contacts of the research team, as well as postings on personal, professional, and alumni Facebook pages, and a discussion forum on AOTA's community. Follow-up invitations were sent out on Facebook and community at 4 and 8 weeks after initial postings to facilitate a greater response rate. The survey consisted of 3 sections: demographics, evaluation and intervention, and practice statements. Demographics included professional designation, years of experience, highest level of OT education, etc. Evaluation and intervention asked the respondents to rate on a Likert scale the frequency of use of various occupations during the evaluation and intervention process, as well as contextual and personal factors evaluated. The Likert scale was rarely 0 to 25%, occasionally 26 to 50%, often 51 to 75%, and regularly 76 to 100%. OTs were asked about evaluation and intervention, while OTAs were asked about intervention only, as OTAs do not conduct initial evaluations. Open-ended questions were used to gather information about specific assessments and general interventions used. The last section of the survey examined the respondents' level of agreement to various practice statements related to the provision of occupation-based services using a Likert scale. The Likert scale consisted of strongly disagree, disagree, agree, and strongly agree. More detailed information was gathered regarding occupation-based services through open-ended questions related to the use of occupation-based models, supports and barriers to providing occupation-based services, and strategies used to overcome perceived barriers. Data analysis was done descriptively using frequencies, means, and standard deviations through the use of JASP, an open source statistics program. Invalid and largely incomplete responses were eliminated. All Likert scales were coded into numerical values. Responses from open-ended questions on evaluation and intervention were put into frequency tables, and general themes from open-ended questions on practice statements were also gathered. There were 45 valid responses to this survey. A majority of respondents were occupational therapists, had 1 to 5 years of experience in acute care, practice in the Northeast, and have an entry-level master's as their highest degree. The next 3 slides will show bar charts of the 3 categories of occupation where at least one area of occupation has a mean greater than 2, which indicates it's utilized more than occasionally. The vertical or y-axis represents the mean of the numerical coding from the Likert scale. The green bar represents how often an occupation OTs use an occupation or observe an occupation during the evaluation process. The blue bar represents how often OTs use each occupation as an intervention, and the yellow bar represents how often OTAs use the following occupations as interventions. Despite a small sample of OTAs, their results were still separated out due to their focus on intervention. The ADL graph shows from left to right functional mobility, hygiene/grooming, dressing, toileting, feeding, bathing/showering, and sexual activity. According to the graph, OTs are using occupations as interventions more than actually observing them during the evaluation process, and address ADLs as an occupation more often. This graph shows the occupation of health management, which is a newly developed occupation in the OTPF4. Health management encompasses physical activity, personal care device or adaptive equipment management, social and emotional health promotion/maintenance, communication with the healthcare system, medication management, and nutrition management. This occupation is not addressed as much as ADLs, but most of health management is addressed occasionally and/or often. As an intervention, personal care or adaptive equipment management is addressed the most compared to other health management categories. Instrumental activities of daily living, or IADLs, which include safety and emergency management, communication management, home management, financial management, caring for others, meal preparation, religious and spiritual expression, driving and community mobility, caring for pets, shopping, and child rearing. This area of occupation is addressed less than ADLs in health management. However, some IADLs were addressed often, such as safety and emergency management. The occupations of rest and sleep, work, play, leisure, and social participation were rarely addressed and therefore were not included here. This graph represents an overview of what contexts and personal factors are evaluated in acute care. From most to least addressed, they are the human-made environment, products and technology, supports and relationships, natural environment, personal factors, services, systems and policies, and attitudes of others. When respondents were asked about specific assessments used to develop an occupational profile, 29 assessments were identified. However, only 3 were determined to be relevant assessments to use to establish an occupational profile. These were an occupational interview, the Canadian Occupational Performance Measure, and the interest checklist. Furthermore, when asked about performance-based assessments, which involve observing performance while completing an occupation, 22 were identified, but only 9 are considered performance-based assessments. Some include the Functional Independence Measure, the Barthel Index, and the Cognitive Performance Test. To an open-ended question, 36 respondents identified at least one intervention they used in acute care. This table highlights the interventions identified most often. The respondents were also asked to identify occupation-based theories that they used to guide their practice. Out of 45 respondents, 16 answered this question. Some did not provide models grounded in occupation, such as the medical model, children's play model, and mixed methods. These are the mean results of the Likert scale responses to practice statements. These means show practitioners agree they are using occupation-based services in acute care, but disagree that factors such as the environment and staffing levels support the implementation of occupation-based services. Responses to questions about the supports, barriers, and strategies to overcoming barriers and the provision of occupation-based services were grouped into general themes. The supports are on the left and include the hospital environment, available resources such as time, material/equipment, and staffing, and recognition of OT's distinct value. The barriers are listed on the right and include lack of resources such as the environment, material/equipment, and staffing, hospital system factors, lack of role recognition, patient factors, and practitioner factor and /knowledge were also identified. A few of the general themes relating to strategies for overcoming barriers to occupation-based services were organizing schedules, creativity and advocacy. Organizing schedules involve schedules of the patient, practitioner, and other staff. Creativity encompasses keeping function in mind, flexibility, simulation of tasks, environmental adaptations, and caregiver/family involvement. Similar to the literature, the results indicate that ADLs such as functional mobility, hygiene/grooming, and dressing are the most frequently utilized occupations in acute care. However, it appears that practitioners are also focusing on other areas within the newly added occupation of health management, more so personal care device or adaptive equipment management, which is not unexpected as is previously considered an aspect of ADLs. Other areas within health management would also be relevant to emphasize in acute care, such as medication management, as it is shown in the literature that it is associated with decreasing hospital readmission rates. Respondents in this study show that practitioners value the use of occupation-based services. One respondent added, the ability to engage patients in ADLs and provide feedback, education, and strategies in the moment. However, similar barriers as identified in the literature, such as time constraints and the practice setting, have seemed to continue to be barriers to occupation-based services. It is relevant to note that occupations were used more in the intervention process as opposed to the evaluation process, which is likely due to time constraints. Even though higher spending on OT services, specifically occupation-based services, decreases readmission rates, there are still barriers relating to the role recognition and value of OT as indicated by these comments. Having PTs take the lead, and physicians and residents not fully understanding home environment and support challenges. This was also found in the literature where OT was perceived as not distinguishable from PT, masking their distinct occupation-based value. Furthermore, this study revealed that there may be decreased use of and understanding of occupation-based theory by practitioners. This was evident based on comments such as, the occupation-based models are terrible, and the decreased number of practitioners who identified the use of specific occupation-based models. This is also similar to prior research where practitioners felt disconnected from the core principles of OT. It is important for practitioners to show the distinct value of occupational therapy by utilizing occupation and occupation-based services. This distinct value should be demonstrated in all practice settings, including acute care. The results of the study show that practitioners are using occupation-based services more so as an intervention than an evaluation. However, the focus predominantly remains on ADLs. This is likely due to the practice setting where the emphasis is on stabilizing patients and fostering increased independence in mobility and self-care for the discharge planning purposes. The results of this study have implications for education, practice, and further research. The results of this study could inform entry-level education to help prepare future practitioners who can be agents of change within the acute care setting. This is a setting that is still dominated by the medical model. OT programs can help prepare their students to overcome barriers and incorporate occupation other than ADLs into acute care practice. Of relevance is the newly created occupation of health management. With regards to continuing education and professional development, it is important for practitioners to be able to explain and articulate the use of occupation-based theories to guide occupation-based practice. It would be relevant to stay abreast on advancements in the profession, such as the OTPF4. When it comes to implications for practice, practitioners who are running into similar barriers providing occupation-based services can utilize strategies identified by respondents in the study. Here are just a few examples. Attempt to schedule sessions around the natural timing of desired occupations, keep functionality in mind, be creative, and I try to simulate home environment the best I can in their hospital rooms. Furthermore, advocacy is important to gain access to resources needed to provide occupation-based services. For example, access to ADL items and assistance from other staff. Emphasis on other areas of occupation, such as health management, will be relevant, especially in light of research that indicates that this helps lower readmission rates. Interdisciplinary education is critical to foster a greater understanding of the distinct value of occupational therapy services through in-services. Finally, practitioners can use the results of the study to encourage the use of occupation-based services in the acute care setting. It showcases the distinct value of OT and allows practitioners to advocate for the increased utilization of OT services since it lowers readmission rates. Implications for further research include gathering more of an OTA perspective surrounding occupation-based services in acute care, given the low number of OTA respondents in the study. Further studies could also examine the current curriculum of entry-level OT programs to determine what is being taught with regards to occupation-based services in acute care. Finally, strategies provided in the study could be further examined to determine their effectiveness in providing occupation-based services in acute care. Limitations to the study include a small sample size, an unintentional exclusion of including the occupation of education as a choice on the survey. Responses may have been based on whether the occupation was addressed through discussion/education rather than performing them based on the true definition of occupation-based. In COVID-19, since it was unclear if the respondents were referring to their practice before or during COVID-19, which may have varied their answers. I would like to thank my thesis advisor, Dr. Shannon L. Scott, for all of the Zoom meetings, replies to constant emails, and passion she has provided me throughout this project. I'm a better writer and researcher because of her guidance, and I could not have done it without her. I would also like to thank my committee members, Dr. Julie Dorsey and Alyson Pasquale, for always providing a fresh, creative, and big picture perspective. Thank you to my parents for everything they have done for me to help me get to this point. Finally, I would like to thank my family, friends, peers, and the entire OT faculty who always pushed me to be the best version of myself possible and have given me so much support during my time at Ithaca College. Thank you. My references. And any questions?
Fantastic work, Matthew. Very interesting. Lots of good things in there. Congratulations. If you can open the floor to questions, shoot them to Jenna in the chat, or if you want to raise your hand, I'm happy to, you can unmute yourself and ask a question.
We do have a couple questions in the chat. I know I can't personally see everybody's screen, so hands up if anybody else, Michelle or anybody wants to respond to those. So we do have a few questions. Jen asks in the chat, Matt, have you identified any relationships between years of practice or education level and the use of occupation-based practice?
Yeah, that's a good question, Jen. Unfortunately, I wasn't able to make those comparisons due to a smaller sample size, but that could definitely also be an implication to further research about experience, because it is found in the literature that experience does play a role in providing not potentially occupation-based services, but more comprehensive services and thorough services in acute care settings.
Great, thank you. Mindy, it looks like you might, is that a hand up or no? No, okay. We have another question in the chat here. Kayleen asks, because this is an individual research project, I'm curious as to why you picked this topic or what motivated you to look into this topic.
Sure, that's a great question. I, coming off of adult block in senior fall and kind of moving into that individual thesis prep course with Mindy, I just remember thinking back to all the conversations that we had in concepts in adult lab, where we kind of looked at various case studies, and we had a very occupation-based focus in regards to those case studies. But I remember a lot of them being more geared towards outpatient practice, especially in kind of the seminar setting too, in class. So I kind of saw this disconnect in hospitals as kind of an area that interests me. So I wanted to see where or how much occupation is being incorporated into this medical model practice setting, because this is a setting that I know we've talked about in class, that it's very biomechanical, very medical model for the most part. So I wanted to see how much of that was actually true.
Looks like Diane has a question. Go ahead and unmute.
Hi, thanks, Matt, so much for this topic. It's really important, and you did a really excellent job. I thought, you know, having just gone through a whole lot of this, one of the things that really struck me was that health literacy piece and the home management piece, coming home with someone who had a relatively complicated home situation and having had about 15 minutes of training by a brand new nurse in the hospital, it was clearly not enough. And I think my question to you is how do we, or what do you propose for occupational therapists who do work in acute care? How do they get the message out that they are the ones who should be doing that training, you know, pre-discharge, and that it should be more than a 15-minute kind of thing? I mean, my first impression when I got home was, oh my goodness, thank goodness I know a little bit about what I need to do here. But it still took me about 3 hours to organize myself at home. So how do we get that message out as clinicians who are working in acute care?
Yeah, I definitely think it's a strong advocacy piece that I talked about in my implications, just because going back to that statistic of 72 to 79% of patients in the study I looked at did not receive OT when it was clearly a valuable service, since it was the only discipline that lowered readmission rates. And I think also it kind of goes to advocacy with other disciplines, just because it seems, especially with some physicians and residents, we found as I was going through my responses that maybe there's a little disconnect to, you know, could OT services be appropriate, because they might not be fully aware of that occupation-based lens that we take. So I think just maybe the in-service idea, and just kind of practitioners saying, you know, this is what we do and this is how it can be helpful. And I mean, there's definitely evidence to show clinicians behind that, but I think with some major advocacy, we can be a larger part of interdisciplinary teams to help prepare families and patients to go home. And like you were saying, it's a really great point of there's a lot to know, and a health management piece can really help OT shine as a distinct value in acute care.
Jenna, it looks like we have time for one more quick question, if there is one.
There is.
Our last, yeah.
Okay, so last question from Jess Valdez-Taves. Were there any suggestions for improving occupation-based practice in acute care, or do you have any ideas after completing this research?
Thanks, Jess. I think definitely just the strategies that I gathered. I was only able to read a few of them, but there were so many great responses that I got from various practitioners about how they incorporate occupation into their practice. And the biggest ones that I found were just really doing your best to keep functionality in mind and really show that creativity that I mentioned earlier, because I think that's another area that we've kind of been presented through the curriculum of how we can be creative as future clinicians and really find unique ways to incorporate occupation into our everyday practice. So I guess based off of that, my advice would be to not give up and be creative, and it's possible. I think the results of my study definitely show that it's possible to do so. So keep trying.
Great, congratulations. Thank you so much, Matthew. Wonderful work. Very important for our profession. Very good, thank you.